Thank you very much, and I want to thank Sages for inviting me, and my boys thank you as well, because they don't like it when I talk, so I'm not talking to them right now. There's been a lot of references to the airline industry, so I will put a plug in for this book that's called Why Hospitals Should Fly. It's by John Nance. We actually have our med students read that, and I actually read it, and it's very interesting, and if you get the opportunity, please do read it. So, clickers. I don't get a hold of clickers at my house either, so not with the boys. I don't have any disclosures, and although I have identified these objectives, probably the most important thing to get out of this is that communication is extremely important, especially about what happens in the OR. Some quick basics regarding communication, just the definition from the Webster Dictionary: the act or process of using words, sounds, signs, or behaviors to express or exchange information or to express your ideas, thoughts, feelings, etc. to someone else. And in terms of the healthcare environment, I've identified between oral and written communication because I feel that's the way that we've really we communicate with each other. Oral communication being the face-to-face, telephone calls, telemedicine, Skype, and I know there's going to be plenty others coming down the pike as well. Written communication, progress notes, dictation letters, faxes, emails, text messages. I do want to caution anybody who does use social media or any of those other text messaging to be very careful with HIPAA and compliance with your facility. Also to be aware that if you are using letters or emails, to not automatically assume that the other person on the receiving end is getting that, number one, and number two, reading that. And again, my son just came back from spring break and didn't read an email that his flight had changed and he missed his flight $540 later. I divided communication into the 5 W's, going back to some really basic stuff: the who, what, where, when, and why. Who, communicators being the surgeons, the anesthesiologists, nurses, PAs, surgical techs, others, to the receiving end, the communicatees. The primary care is the hospitalists, the PAs, again, nurse practitioners, nurses, any therapists, family, and any office staff. What are we sharing? We are sharing surgical information, particularly the name of the procedure, findings of the procedure, specimens removed, estimated blood loss, intraoperative complications, and anesthesia complications. Either a history of those complications or their current problems they're having with anesthesia and coming off of it, because that can lead to some devastating results if the patient has some ill effects from anesthesia that we don't address. Where are we given this information? We're giving it to the PACU, the recovery room. We're giving it to the hospital unit. We're giving this information to primary care offices, other providers' offices, to family and others who may need that. And we're doing this immediately after surgery or when the next availability is to discuss with the provider or family. And why? The most important reason being because we want to prevent negative patient outcomes. We want to expedite patient treatment and continuity of care. Some barriers in communication include, and I'm not going to go through this whole list, some personality differences, some cultural and ethnicity, some differences in language and jargon. And I'll tell you, let me make sure none of my surgeons that I've ever worked with are here. I had a discussion with one of our surgeons for a readmission we had. It was a patient who was coming in right after surgery, was eating food that he shouldn't be eating, but he couldn't specify, the surgeon couldn't specify exactly what those food products were because the patient wasn't forthright to him. So I went to go admit the patient. I got the whole history and physical and went to go speak with my surgeon. And I said, I got it out of him. And he looked at me, and he's from another culture, and he looked at me and his eyes are like, are you kidding me? You took it out of him? And I said, no. I got him to fess up what he was eating. So you need to be careful with some of these barriers that you may not be aware of, including some of these others as well. So what happens with poor or lack of communication? It can lead to delays in assessment and diagnosis. It can cause inadequate monitoring of a patient's condition, altered patient management and care, and lead to inappropriate treatments and unnecessary testing. or it can delay discharge from the hospital, cause the health team to miss some red flags. I had a patient who had gastric bypass and they nicked the spleen. And that information never went further than the OR. It didn't go to recovery room. It didn't go to the staff outside of the recovery room. And that was something that we really needed to know, but because they wanted to protect the surgeon, that information was not shared. So it is important. We need to keep, monitoring these patients in the post-op period, and even for your office staff as well. It can cause disruption in continuity of care and have a negative impact resulting in death or permanent loss of function. And in fact, silence can kill. There was a study, Vital Smarts in the American Association of Critical Care Nurses, that was related to communication in healthcare, that suggested nearly 3 in 4 medical errors are caused by mistakes in interpersonal communication. And Big Brother is watching. We, Joint Commission had published their data from 2004 to third quarter of 2015 and found that the root cause for post-op and operative complications that resulted in death or permanent loss of function was related to communication. It was the number 2 cause. So this year, this is one of our national patient safety goals, is to improve staff communication, to get important test results to the right staff person on time. Here are just some suggestions. This is coming from AORN, using some type of process to transfer that information, including SBARs or I pass the baton, and make sure you educate, train, and validate an effective communication skills and process for the transfer of patient information. Although this is related to specifically given the information in the post-operative phase, I do want to stress that it's important in the preoperative phase, because as many of you will know, and I'm sure this has happened to you, that you don't get the appropriate information from the primary care, from the specialist, from the nursing staff on the unit, and that can delay and or cancel your cases. So I do think it is a two-way street, and that good communication encourages collaboration and helps prevent errors. And if you have any questions, please feel. Oh, I have a quick story for you. So this morning we went out for breakfast, my colleagues and I thought, well, geez, this is really related to communication. We're sitting at the table, and all of a sudden, one of the, I think he was a cook, comes over, and he says, he starts looking directly at me, and he says, "Don't do it." I'm like, okay, what? Don't do drugs. I said, all right, how come? He said, well, I used to do drugs, and I've been clean, and one of the staff heard you wanted to do LSD, and don't do it. And I thought, what is he talking about? And my colleague said, remember you said you wanted to get one of those drug rug sweatshirts? They're the Mexican sweatshirts. People call them drug rugs. I said I wanted one. He thought I wanted to do drugs and LSD. So there you go, the importance of communication and being able to understand what people are really saying. I don't want to do drugs. And that's what I have.